Session on myopia, a closer review. So we'll kickstart with Dr. Mallika Harikrishnan speaking on an overview of the myopia pandemic.
Good morning, one and all. Thank you, Dr. Samyukta and KSOS for this opportunity. We all remember the spirit, outbreak of a lockdown. It was a pandemic. Children were forced to stay indoor and attend online classes. Parents working at home, forced to hand over the digital devices even to the infants. Overindulgence and dependence on youngsters, often youngsters on digital gadgets. And what did it result? There was increased incidence of myopia and increased progression of already existing myopia. But even before this pandemic, the tendency was seen in many of the countries like Taiwan, Japan, Singapore, etc. The study shows that the prevalence of myopia exceeds 80% in some regions of East Asia, and there is 2 times higher prevalence of myopia in these countries than in Caucasians of similar age. What do they think as the cause for this high pressure education system? That is why I am here to talk about an overview of myopic pandemic. It won't be an exaggeration if I say that any other pandemic is, one more pandemic is being faced by the new world. One of the staggering trends in ophthalmic care has been the rapid rise in the myopia. So where do we stand? There is rapid rise in myopia which is associated with several pathological changes leading to irreversible vision loss. The prevalence of myopia in young adults in urban areas in East Asia is 80 to 90%, and that of high myopia is 20%. This is a graph showing the number of people estimated to have myopia and high myopia for each decade for 2000 to 2050. It is quite alarming, no? There is rapid global rise in the myopia, and the prevalence of myopia exceeds 28% globally. And the projection is that there will be approximately half of the world's population, or 5 billion people, will have some degree of myopia by 2050. Not only that, 10% of the world will have high myopia, 2-fold increase in the myopia prevalence. Number of people with vision loss resulting from high myopia would increase 7-fold from 2000 to 2050. What is the scenario in India? The prevalence of myopia among Indian urban children is predicted to increase from 20% to about 48% by 2050. 5 out of 10 children living in urban regions of India are likely to have myopia by 2050 if anti-myopia measures are not initiated. 2 out of 10 children in India are known to have rapid myopia progression, and the myopia progression is rapid in children who develop myopia at a younger age, and about 4% of Indian myopes tend to have complications that can lead to permanent vision loss. So more than just the need for spectacle correction in these people, chronic pathological changes are likely to happen in these children, like retinal detachment, myopic macular degeneration, glaucoma, amblyopia, and early onset cataract. So what are the causes of this myopization instead of emetropization? The proposed causes are genetic factors, environmental factors, accommodative factors, peripheral retinal hyperopic defocus. These will be dealt in detail by the subsequent speakers. Among the genetic factors, I would like to say that there is increased risk of myopia in children having 1 myopic parent, odds ratio being 1.87, and 2 myopic parents, odds ratio 2.47. animal studies suggest that the importance of environmental factors, that ultraviolet light may inhibit axial elongation by stabilizing the sclera. So spending 76 minutes a day outdoors result in 50% increased incidence reduction of myopia when compared to control eyes. The odds of myopia increase 2% for every 1 diopter hour more near work performed at each week. What is meant by this peripheral retinal hyperopic focus? Hyperopic defocus in the mid-peripheral retina driven by negative lens-induced myopia in turn leads to posterior scleral remodeling, choroidal thinning and eye lengthening. Is there any solution to these? Preventive therapy for myopia progression currently has 3 aims. 1. To screen patients with high risk of progression. 2. To stabilize the myopic progression. 3. To provide optical correction for healthy visual development. An increased emphasis on slowing myopic progression with effective childhood screening has been adopted by children in the primary care for children by the clinicians in primary care, pediatrics and ophthalmology. These are 2 hours of outdoor time activity, minimize digital screen time, and examine eyes early in one or more parents are myopic. And children should have minimum 9 hours of sleep and adults should have minimum 7 to 8 hours of sleep. So there are other armamentarium in our hands like low dose atropine, orthokeratology lenses and contact lens like multifocal, aspheric and bifocal. So to conclude, myopia is a common cause of vision loss, and with uncorrected myopia, the leading cause of distance vision impairment globally. The treatment for preventing myopia progression is reliant on effective screening and initiating treatment early in life, and there are implications for planning comprehensive eye care services and multifaceted myopia control system to buffer this scenario. Thank you so much.
Thank you, Dr. Mallika, for the detailed overview. Next, I invite Dr. Samyukta for her talk on understanding the pathomechanisms of myopia.
Good morning, everyone. I'll be speaking on the pathomechanisms of myopia. In that backdrop of myopia being projected as a global public health concern, we need to be knowing what is happening exactly inside the eye. So this is more of theory, kindly bear with me. So how does this refraction develop from neonatal age into adulthood? Need to know what is emmetropization. So this is an active regulatory process that starts in the postnatal period and gets completed by 6 years of age. So what is happening here? There is a precise matching of the axial length with the optical power of the eye. And any disruption in this active process leads to refractive errors. These are the developmental milestones. At birth, the range of refraction follows a Gaussian distribution, with the newborn having a moderate myopia in the range of +2 to +4 diopters. And in the first year, there is a reduction in the hyperopia due to the modulation of the axial growth. So in 3 months to 3 years, there is a progressive shift in the main refraction from +2 diopter to +0.75 diopters. And after the age of 6, divergent patterns of refractive development are noted. So axial length is the most influential factor which decides the myopia genesis. At birth, it is around 70 millimeters. By 1 year, due to the expansion of the vitreous chamber, it elongates to 20 millimeters. From 2 to 3 years, axial elongation slows by 0.4 millimeter per year till the preschool age. It gets stabilized by 6 years and increases only by 1 or 1.5 millimeters through the teen years. So two basic mechanisms operate in bringing about the development of a refractive error: form deprivation and optical defocus. So in form deprivation, the quality of the image formed on the retina is degraded. So the absence of a visual feedback results in choroidal thinning and axial elongation. The figures show the directional change in the axial length with regard to optical defocus. So in optical defocus, the focal point of the image is altered with respect to the retinal plane. So many theories have been proposed over the last 40 years. So much of research has happened in this area. And the key factor is thought to be genetic susceptibility to environmental factors like near work, night light exposure, diet, and stress. So how does this genetics work at a biochemical level? Creation of weak or degraded connective tissue is a key factor. So a known genetic factor is implicated in syndromic conditions like Marfan syndrome and CSNB. This recent genome-wide association study named CREAM found 24 loci associated with myopia, and all these are thought to increase the risk by up to 10 folds. So this has already been told, the impact of parental myopia. Both parents are myopic means the risk in the child is increased by 2 to 3 times. And if only one parent is myopic, the risk is increased by 1.5 times. Environmental influences, it has been studied that the indoor light peaks at a longer wavelength. Sunlight peaks at a wavelength of 550 nanometers. So most of the beams which are received by the eye get focused behind the retinal plane, and that is a stimulus for myopia genesis. These are the different factors proposed: outdoor environment, chromatic composition, dopamine, vitamin D, and these lifestyle-related contributors: reading distance less than 30 centimeters, urbanization, educational level intelligence, digital screen time, all these are thought to contribute. These are the different ocular expansion models: global, equatorial, axial, posterior pole, or it can be an asymmetrical expansion as well. Now, what is the role of retina in regulating the eye growth? It is thought that the retina has an inbuilt retinal image defocus detecting system which acts within the eye, and the retinal neurons also secrete a number of regulatory neurotransmitters which are thought to directly alter the ocular growth. Dopamine is thought to be a stop signal for myopia genesis. So a blur stimulus at the retinal level initiates a cascade of cellular and biochemical changes which are transmitted across the choroid and finally result in remodeling at the scleral level, responsible for increase in ocular axial length. It has been studied that equatorial and pre-equatorial regions, the retinal thickness is much thinner, but no change has been noted in the foveal region. And it is important to know that both central and the peripheral retina are important in driving the refractive status. This also has been told, the peripheral retina in myopes exhibit a relative peripheral hyperopia, and the peripheral, as is seen in the second image, the peripheral retinal image is focused behind relative to the central focus, and that serves as a driving force for increasing the axial length. What is the role of choroid? The choroid is high, with its vascularity, it is responsible for maintaining the ocular temperature, intraocular pressure, and it acts as a transfer channel for all the retinal signaling molecules to the sclera. Thinning of the choroid has been found to be the structural hallmark of human myopia. These are the changes which happen in the scleral level. There will be scleral tissue redistribution characterized by thinning of the collagen fiber bundles, reduced glycosaminoglycans and collagen contents. And it has also been studied that sustained accommodation during near work causes a thinning of the anterior sclera, mainly 3 millimeters posterior to the scleral spur. That is related to the peculiar pattern of arrangement of the longitudinal fibers of the ciliary body. These are the two theories suggested, mechanical tension theory and the accommodative lag theory. Mechanical force exerted by the ciliary body or the lens on the anterior part of the globe during accommodation is thought to accelerate the ocular growth. Similarly, the central hyperopic defocus is associated with a lag of accommodation during near work. That is also thought to contribute to ocular growth. And it is also studied that near task in down gaze changes ocular corneal astigmatism. It also induces some amount of higher order aberrations, because of which retinal image quality is affected. And it is understood that positive spherical aberrations are more protective than, they are protective. They actually inhibit the ocular growth. Near-induced transient myopia, thought to be due to a deficit in the sympathetic or parasympathetic input, is another entity. Convergence and extraocular muscle stress is also thought to contribute. And there is this on-off pathway that is also thought to have some role in myopia genesis. This is a concise model. Thank you.
Thank you, Dr. Samyukta, for that excellent talk. Next, I invite Dr. Anita Prabhakaran for her update on progressive myopia.
A very good morning to each one of you present here. So we are going to talk about something very important these days. We have been finding this very often, much often than what we have seen when I started my practice somewhere in 97. This is really something which is on the surge. So first of all, let us just define what is progression. Progression means when the myopia increases more than 0.5 diopter per year or an increase in axial length of more than 0.1 millimeter per year. So that is the definition of progressive myopia. And one more thing which is actually progressing is the prevalence of myopia as well. As has already been described, the prevalence of myopia in Indian children has also been on the increase. So that is also another progression we are noting. So risk factors for myopia holds true for risk factors of progressive myopia as well. Most of them, like age of onset, earlier the onset, more the risk of progression. Females, they say the reason is being females are more prone to be indoors. Parental myopia has already been described. Asian ethnicity, it's been found that children of Asian origin, even if they reside elsewhere, they are still found to have progression in myopia, and that is postulated to be attributable to the parents being highly academically and oriented, and they insist that the children, more than the other nationalities, Asian children are more into academics, and that is supposed to be one of the reason. Again, early schooling and curriculum, same reason, and of course increased near workload, which Samyukta mentioned about the accommodation influence, and the syndromic associations like Marfan's have already been mentioned. Genes have a important role to play. Baseline refractive error, we said we categorize about plus 0.75 to minus 0.5 diopter baseline refractive errors to be pre-myopes. We have to take more care so that they don't progress to progressive myopia. And visual environment has already been mentioned, but I'll talk about it a little bit later. And relative peripheral hyperopia, lack of accommodation, and esophoria for near is also noticed. All of you must have heard of the bullet trigger theory, that is a gun loaded with bullets of children with high myopic parents is like a pistol loaded with bullets, and whenever there is any risk factors, like any of the risk factors, it's actually a trigger being pulled, and more number of triggers being pulled, more number of damage and more complications follow. Ocular expansion has already been mentioned, how globally, equatorially, only the posterior pole, axial or an asymmetric enlargement of the globe happens, and the various postulations have been, most importantly, one has been because of the changes in the sclera, because of the proliferation of the chondrocytes, and the ocular muscle pull because of the accommodation convergence, abnormal correlation. And another postulation is the adolescent stage. There are lots of internal changes happening which leads to the rapid growth, and calcium deficiency has also been postulated in a study, and it could be, in a way, when we are now talking about that vitamin D is a reason for a progression of vitamin D deficiency is a reason of progression of myopia, and it could be related to calcium deficiency as well. It's yet to be, lots of study need to be done. So as we all know, why are we worried about progressive myopia? Because higher the myopia, once it goes into the pathological myopia, there are more risks. I just wrote very few. There are lots of risks, just like Dr. Mallika explained, like there are amblyopia, glaucoma, cataract, myopic macular degeneration, lacquer cracks, SCNVM, staphyloma, retinal detachment, so on and so forth. So why are we concerned about how can we really control the progression? So one factor we need to remember is that the risk of developing myopic maculopathy decreases by 40%. It's very significant if we control the progression rate, but by at least 1 diopter during childhood. So this was actually, this came up in the impact management guidelines. I'll come to it at the end of it. So what are the various interventions we can do? There are pharmacological interventions, there are optical interventions, very important. Added to all these would be lifestyle modifications, and a recent light therapy has also been mentioned. So about pharmacological measures, we are all dealing with muscarinic receptors or xanthine derivatives or IOP lowering agents, of which muscarinic receptors holds good even at this time, and of which the most commonly used one is atropine of various concentrations, 0.01%, 0.25 and 0.5%, but the one which we most commonly use and is commercially available is atropine at 0.01%. It's actually it's a muscarinic antagonist acting on all receptors, but the M1 and M4 receptors are involved in the myopia control, and we need to understand that atropine does not affect the progression of myopia through an accommodative mechanism. All of us might think that this is because of the pupil dilatation. No, this is actually it's a non-accommodative mechanism. How it does is it has a effect on the dopamine neurotransmitter release, and this dopamine is actually what is affecting the control of the it has control on the retina and the sclera, and therefore it affects the progression in length of the globe. So the low dose atropine, usually in clinical practice we start now the consensus is start by around 5 to 15, in between children in 5 to 15 years, and the progression needs to be documented. Only when the progression is documented you need to start. You need to do cycloplegic refraction, axial length measurement, pupil size, accommodation and visual acuity, and after 1 year if there is poor response is children who progress more than 0.75 even after the atropine. If less than 0.25 it's considered as good responder, and between moderate response. So usually we give for 2 years, and then after 2 years we start tapering. That is what what is recommended. And optical treatment is especially when those with relative peripheral hyperopia, which is demonstrated by peripheral refraction, we should go for peripheral defocus glasses or multifocal lenses or orthokeratology. Or those with MEM refraction, we get an accommodative lag or near-esophoria, you go for bifocals or extended depth focal. So lifestyle modification very much to be emphasized. At least 90 minutes or 2 hours per day of outdoor activity in good sunlight, and take breaks. Allow only 30 minutes of screen time and maintain posture. And low level red light therapy is another new thing coming up. We are not using it. So it has to be tailored. It's nothing like one size fits all. We need to look at various options and decide, especially in case of optical measures, we need to think about the parents' financial capabilities as well. So there were studies, Atom 1, Atom 2, LAMP, and the impact study. Impact guidelines have been put up in the recent IGO, and they all deal with how we can manage the progression of myopia. So as we can see here, every 1 diopter increase in myopia, this is how the child gets blurred. So it does affect their academic and socioeconomic. It has a big socioeconomic burden, and therefore it is the need of the time to control progression of myopia. Thank you very much.
Thank you, madam. Over to Dr. Naina Jabin Haider, madam, for her talk on pseudomyopia, diagnosis and management.
Good morning to you all. I see we have a big crowd, at least for myopia. And my topic today is pseudomyopia. It will throw you off guard because we've been discussing myopia so far. So I have been tasked with pseudomyopia. So coming to a clinical scenario, we usually sometimes do get these type of patients. Like a 10-year-old boy who had defective vision for distance in both eyes, was not able to see the letters in the whiteboard in school and eye strain, brought in by the mother, anxious mother, and the best corrected visual acuity was -5 diopters, and he gave a 6/6 correction, cycloplegic refraction. We usually in our setup we do a hometropin refraction, and that came as +0.5. And the refractionist who's with me came and told me, "Madam, this is the refraction I've got." And I looked into it, and there was no strabismus, and the refractions was telling the accommodation was active during retinoscopy. The pupil size was keeping changing. The accommodation was intact. So I did order in atropine refraction, that is with an ointment. We usually do give eye ointment because the mother was anxious. I didn't want to have any allergic reaction. So anyway, we did atropine, and to do us this, it came as +0.5 diopters. So this all attributes to accommodative spasm. So this spasm was described by von Graefe in 1856, pseudomyopia or spurious myopia. And here the tone of the ciliary muscle is increased. The power is there. The far point and near point are closer, but the muscle is unable to relax. It's all held up with the biceps and the muscles together. But the changes in the refractive error is towards myopia. That is, when you have a hypermetropes, they become less plus, myopes become more minus, emmetropes become also minus. This is the shift you see in pseudomyopia. But as the earlier speakers has told, the axial length, whereas in progressive pathological myopia, in pseudomyopia, the axial length is going to be normal because the hypermetropic refraction will be plus 0.5. And when you do a corneal curvature, doing a keratometry, the corneal curvature is also going to be normal. So that is going to give you the diagnosis of, are we dealing with a pseudomyopia? Because we won't have a change in the axial length or the corneal curvature for the age. And usually these patients come with blurred, distant vision, macropsia, anesthetic symptoms, headache, eye strain. The diagnosis is usually that the child or the adult will eat up the minus lenses, because if you give 0.25, 0.5, they just go on accepting, so happy to accept more and more. And there will be a variable objective and subjective refractions in these patients. The range of accommodation will be abnormal for age. The fogging test, sometimes the refractions do them, but they cannot relax the accommodation because the patient keeps on eating up the minus lenses. And the pupil size, the meiosis is there. You can see the changes in the pupillary size. The variability with the beakocycloplegics. Sometimes you do get esotropia, which is can be plus or minus in these patients. And coming to the types of pseudomyopia, it is divided as functional and organic, that is Duke Elder. So the functional pseudomyopias are common. They are in school-going children, adolescent, young adults, pre-presbyopia. So you don't have that myopia in the child, you do have it around the range of the population. And you do get it in intermittent exotropia, has also been said to have a pseudomyopic element to it, convergent insufficiency also. So these are the factors you have to look into a patient with myopia, the axial length, corneal curvature, the accommodation, the pupil size. So convergence, everything has to be looked into it. Myopia, as we all talk about it, but there are so many factors we do have to keep when we have a patient with myopia. And treatment for functional myopia is sometimes difficult to treat. The corrective glasses are given with the correction of astigmatism because we have to relieve the child or the adult with the glasses. We are forced to give the glass, and visual rest is advised. A persistence in cycloplegia 3 to 4 weeks with hometropin once or twice daily may be required, and sometimes even a period of atropinization may be needed for months. And a +3 you have to, because the child will be having difficulty with near vision, so a +3 plus 2.5 glasses has to be prescribed for near also. And coming to organic pseudomyopia, it is rare. You can have it in myotic drugs when you have pilocarpine for glaucoma, uveitis, uveal effusion syndromes. There are a lot of lists of organic pseudomyopia, and overdose of morphine, digitalis, brainstem lesions, encephalitis, fevers, diphtheria, sulfonamide. So lots of studies, lots of papers are coming with, there was a paper on whiplash injury causing pseudomyopia, head injuries. So there is a chance in these patients to have a pseudomyopia. So to conclude, it is stressful to the patient and doctor. The patient keeps on doctor shopping. We do get these type of patients in. They are not satisfied. The parents are anxious. And sometimes you do order in a full neurological workup in these patients with neuroimaging, because we are not sure, are we dealing with functional or organic? But when we went back to the history with this 10-year-old boy, he came up with, the mother was reluctant initially. His father has passed away recently. The mother was handling all the load as a single parent. The child was stressed. So he was accommodative spasm. And we need the child to, get accustomed to the environment. So we need to sometimes go into details with the family, with the parents to know about all this. And so the need of atropinization and bifocal spectacles is advised, and treatment may prolong for months to a year or more. So to conclude, pseudomyopia has to be looked in patients with myopia also. Thank you.
Thank you, madam, for that. Over to Dr. Ashwati for speaking on pathologic myopia, the current understanding.
Good morning all. My topic today is pathological myopia. So what is pathological myopia? Often we use it interchangeably with the term high myopia, but high myopia is just something with refractive error more than 6 diopters. Pathological myopia is that type of myopia which is accompanied by degenerative changes occurring especially in the posterior pole. A lot of confusion existed as to what to include and what not to include in pathological myopia, but a group of researchers in myopia recently came up with a classification that's known as meta-PM classification. According to that, PM is defined as eyes having chorioretinal atrophy equal to or more severe than diffuse atrophy, or the presence of plus signs, or as eyes having posterior staphylomas. So how much are we burdened by this disease? According to various meta-analysis, in 2015, around 10 million people are visually impaired from myopia, of which 3.3 million are blind. And it's projected that by 2050, around 55.7 million people will be visually impaired from myopia, of which 18.5 million will be blind. So the prevalence of myopic visual impairment is gradually rising from 0.1% in 2000 to 0.6% in 2050. And it is 2 to 4 times almost higher in Asian population as compared to Europeans. What are the risk factors for pathological myopia? These include older age, worse myopic refractive error, longer axial length, and presence of fundus tessellations. So posterior staphyloma is the hallmark of myopic pathological myopia, and that itself can lead to most of the other retinal changes and cathoidal. The pathogenesis has been dealt in detail by Dr. Samyukta, and it's basically the axial elongation causing chorioretinal stretching and various changes in the collagen. Posterior staphyloma, as described by Richard Spade, is an outpouching of the circumscribed region of the posterior pole of the eye that has radius of curvature shorter than the radius of curvature of the adjacent eye wall. Now it is independent of the axial length. Actually, it can occur even in people with normal axial length. Curtin's classification was the most commonly used classification for myopia, but recently a more simplified classification called TDMU classification has been proposed by Ono Matsui. According to that, we have mild macular, narrow macular, peripapillary, nasal and inferior staphyloma. How do you identify a posterior staphyloma? We have wide field fundus photograph on which we can see the pigmentary alterations at the margin of the staphyloma. 3D MRI shows the outpouching in the posterior pole, and there is an ultra wide field OCT in which there is an inward bending at the region of the margin of the staphyloma, and at that region you also notice a choroidal thinning. On either sides there is thickening of the choroid, but at the margin of the staphyloma there is thinning. Diffuse chorioretinal atrophy can be either peripapillary or macular, and peripapillary is the first one to develop. Here there will be a segmental and abrupt thinning of the choroid in the temporal peripapillary region, and the choroidal thickness of less than 60 microns, about 2500 microns nasal to fovea, is diagnostic or 100% specific for peripapillary diffuse atrophy. Now identifying this in children is very important because that is an indicator for eventual pathological myopia or posterior staphyloma in adulthood. Macular diffuse atrophy is often difficult to diagnose, especially in less pigmented fundi, and there will be marked thinning of the choroid in the area of diffuse atrophy. The subfoveal choroidal thickness will often be less than 100 microns. Patchy chorioretinal atrophy rarely affects the central fovea. It can be derived from either lacquer cracks or diffuse atrophy. When they are derived from lacquer cracks, it's almost longitudinal, and when derived from diffuse atrophy, it's almost circular. When you do autofluorescence, you get a uniform hypoautofluorescence at the region. Loss of RP with or without Brooks membrane defect will be seen in OCT, and in an FFA there will be hypofluorescence in the early phase with hyperfluorescence along the edge in the late phases. Myopic macular neovascularization is smaller, less active and more difficult to detect due to background chorioretinal atrophy, and the exudative changes will be much lesser as compared to ARMD related CNVM. It can occur in 3 phases: active, scar or atrophy. The active stage is identified by small greyish membrane in the subfovea or parafovea, and when you take an OCT you can see a highly reflective area above the RPE layer with significant exudative changes, although that would be less than that seen in ARMD related CNVM. In the scar stage, there will be a fibrous scar covered by proliferated RPE cells, and this is known as the Fuchs spots. And in the MNV will be enclosed by the RPE seen in a bright line in OCT. In the atrophic stage, there will be well-defined whitish or slightly pigmented choroidal atrophy, and in the OCT, there will be subretinal elevation with increased penetration of light at the site, and Bruch's membrane will be all tattered and fragmentary. OCT is very useful here because it shows a clear vascular network is in the, at all stages of MNV, and a shrinkage will be noted following treatment with anti-VEGF. And this is especially useful in differentiating it from a simple macular hemorrhage. Fluorescent angiography shows hyperfluorescence in the active phase with dye leakage, but in the scar phase there won't be any dye leakage. A lot of clinical trials like Repair, Radiance and Mirror have demonstrated the effectiveness and safety of ranibizumab and aflibercept in MNV. But unlike in ARMD, a single injection of VEGF followed by PRN treatment will suffice. Lacquer cracks represent healed and mechanical breaks of RP, Bruch's and choriocapillary complex. And in the OCT, it is seen as discontinuities of the RP with an increased penetration of light through the choroid. In autofluorescent will be hypoautofluorescence and hyperfluorescence in an FFA, and OCTA shows a partial defect in choriocapillaries at the site. Simple macular hemorrhage is important because that will herald the new lacquer formation, lacquer crack formation, and in the FFA and autofluorescence there won't be any hyperfluorescence. Differentiated from CNVM. Myopic stretch lines are often another finding. You can see large choroidal vessels that often project into the retina. Radial tracts are also another finding that is seen in pathological myopia, but unlike those seen in CSCR, these are directed upwards from the margin of the staphyloма. In CSCR, they are seen as descending tracts. Autofluorescence is very good in identifying the patterns of radial tracts. And in a large population of those with myopia, there is a peripheral avascular zone, and macular vortex veins are also very common in those with pathological myopia. Myopic tractional maculopathy is one of the most common causes of loss of vision, and it is caused by outward tractional force balanced by inward tractional force of the posterior sternum. There are a lot of classification things, and retinoschisis is the separation of the retinal layers. It can be inner or outer. Outer is more common, and that can lead to even a foveal detachment. And unlike the idiopathic macular hole, the lamella hole will lead to detachment in case of myopia. And when that happens, you can go for a pars plana vitrectomy with ILM peeling and intraocular gas tamponade, and often inverted ILM flap and autologous retinal free flap are effective for better surgical closure. Dome-shaped macula is another finding here. There is more than 50 microns of macular bulge, and you can almost in nearly all cases you can see some SRF, but that doesn't require any treatment. Optic disc anomalies are in plenty, and that makes it difficult to diagnose a case of glaucoma in case of myopia. Intrachoroidal cavitation, you can see there inside the close to the peripapillary region. And optic disc pit and conus pit are also very common, where you see a significant retinal thinning or often absence of full thickness defect of sclera. And there is a lot more, but I am rushing through. Thank you.
Thank you very much, Ashwati, for that. Great pleasure having on board with us Dr. Sandra Ganesh. She is a senior consultant in Department of Pediatric Ophthalmology and Strabismus Services, Aravind, Coimbatore. She is one of the contributors to the AIOS myopia consensus statement. What more do we need? Thank you, madam, for coming over.
Thank you, Dr. Samyukta, for the kind invitation, and I really enjoyed my stay here in Thrissur, such a beautiful place, and made a lot of new friends also. So I'm going to talk a bit of all the previous speakers before me have made my job easy, and many things have been covered, but still I think myopia being a hot topic today, there's a lot to discuss. Every time we have a session on myopia, it's almost like a very good attendance in any conference. So, why do we need to start with this kind of myopia management? So, we did a small study in Aravind Coimbatore. This is comparing the statistics of 2019 to the statistics that we had in 2022. So, you can see the yellow is the new myopia cases in 2019, and the red ones is the new myopia in 2022 across all months of the year. And what we saw was what we had been observing in the clinic, that every single month the number of new myopic diagnoses had really increased. This was just after the pandemic. So definitely we should not be myopic on myopia management. As has already been said about the prevalence, the myopia prediction for India also is around 50% in 2050. So that's why we feel that we do need a dedicated time or space. Like if you have a clinic, if you're running whether any type of practice, you can set aside certain days for myopia management so that we can give the proper, the focus that these need. Or if possible, in our place we have open a myopia clinic as well. So that it's just so that there is more focus to this disease. We have been treating myopia for many years now, ever since I was joined as a postgraduate or a fellow. But what has changed is the way we look and the way we want to treat myopia. So now is definitely the times to start, because our evaluation and management has completely changed over the past 3 or 4 years. Every diopter matters, as has already been said. There is a lot of increase in myopic degenerations with each diopter of increase in myopia. Patients think that it is not important because they can do refractive surgery in the end. But what we need to make them understand is that doing refractive surgery on a -8 eyeball is not the same as doing refractive surgery on a -1 or a -2 eyeball. All the complications of progressive myopia, as my previous speaker has said, will remain the same. Even intraoperatively, immediately we have seen cases where high myopic patients have got retinal detachments a month or two after doing a refractive procedure. So these would be the key steps. Updating knowledge. Updating knowledge, we need to be abreast because there are a lot of updates which keep happening every 3 or 4 months. There is new guidelines. So from where do we update knowledge? Based from there are a lot of publications coming in, evidence-based websites and meetings. Survey your patient base, staff training, workflow process, and then study your results. So this would be the key steps to any myopia practice. Updating knowledge, as I already said, we need to consider each child as potentially myopic because the incidence is going to be 1 in 2. Survey your patient base. As I already said, once you survey your current demographics, around 10 to 15% would be a new myope in any pediatric practice, and identify the pre-myopes. As my previous speaker already said, age related guidelines, any refractive stage in like a 6-year-old, it is within plus minus 0.5, 0.75, it is okay. Then if it is like within more than that, you would think that as a pre-myope. And also when you add the risk factors, which include family history, visual environment, spending a lot of time on ear work, and binocular vision anomalies, which I will be detailing about. So then you consider that as a pre-myope. Pre-myope, why? Because it can be preventive. All the environmental factors that we talk about, once the myopia has already started, it doesn't really play a big role. But it can play a huge role in pre-myope. And staff training, you need to teach because they are going to be dealing with the patients as soon as refractionist. All of the whole department should speak the same language. If each give different information, the patient is going to get confused in the beginning because patient asks questions to everyone, not only the ophthalmologist. So they will ask the refractionist, optometrist, front office staff, everybody they will ask. So everybody needs to speak the same language. So this is the workflow pattern that we are following in the myopia clinic, where we do a thorough risk assessment followed by your clinical evaluation and then a customized treatment plan. It's not a one-size-fits-all. We need to spend a lot of time with the parents, family and the child to understand what will be the best course for that family. So the pediatric refraction, we have given the guidelines to the refractionists so that in the EMR they directly flag us to enter the myopia clinic, because otherwise we tend to miss out a lot of cases even if they are not willing for any glasses or atropine, but still we can do the behavior modification. And also to know the statistics, it's better that you give the guidelines and count all the patients. So power range that we currently follow is we taking up to -8, but we do disregard certain cases which we think are already very high progressive. But most of the guidelines say around like -4 to -6 for giving the glasses. And risk assessment form is filled by parents. Then we do the workup, which includes binocular vision assessment, biometry, then seen by the consultant, cycloplegic refraction, and then we decide on the strategy. Similarly, for review patient, we'll do the refraction, biometry, and we do the progression chart filling, and then seen by the consultant, and again deciding on the strategy. So risk assessment, evaluation, followed by customized treatment. Genetics already has been talked about. So the key points in history will definitely include the age at onset. I think this is one of the most key things, because if you start at around 6 or start at around 12, it's not the same. Because a myopic child who is going to get myopia at around the 6, you are looking 10 years of progression. So the like all the modifications have to be started really early. With parental myopia, again adds on to the risk, near work, outdoor time, prior progression and prior treatment. So this is the bilingual form that we are using. It is filled by the parents when they are waiting in the clinic, so that that reduces our chair time. If we are going to ask all the questions, then it's going to take more time. Then we do like a rough risk stratification. This again is filled by the front office staff, so that consultant gets a rough idea as soon as they come in, whether it's a high, moderate or a low risk. Identification of the true axial myope, because most of the interventions, whether it's low-dose atropine or the control glasses, definitely targets only the true axial myopes. We definitely should not include many cases, which I will just tell you. Whom to treat? Age 6 to 14, simple myopia, stable cylinder. If there is a steep K or a progression in K, definitely need a topography. And insufficient evidence for pathologic or syndromic myopia, we are not treating at all. Myopia with glaucoma, even myopia with prematurity, because the etiology is completely different there. Simple myopic astigmatism, just astigmatism also we are not including for treatment. Maybe you can include that as a pre-myope and just give counseling. And compound myopic astigmatism, cylinder is much more than sphere, even that may not respond to conventional treatment. So this is the binocular vision test we need to do. The most important thing is a cover test. Pick out the esophorias, ACORA, NPA, NPC, because any of these, and MEM value, because over accommodation with esophoria, you need a bifocal ad. So axial length, without documenting axial length, it is impossible to do myopia management. Every time they come, this is the most important metric that you need to do. There are a lot of publications which say now that axial length to keratometry ratio, that is also very important compared to axial length alone. So if it is possible, you can document both the axial length and the keratometry. The clear study says around 0.16 millimeter per year as a cutoff, and this cutoff also varies according to age. So in less than 10 age group, we have a different cutoff for progression. More than 10 age group, we have a slightly relaxed cutoff for progression. The fastest axial length growth actually happens before the onset of myopia. So if we have, but sadly in our practice, it is not, we are not taking for every patient. So we cannot pick based on that. So there are axial length growth charts available, just like how you get a height and weight chart. You can actually plot these kind of charts to see how the patient is progressing. So what can you use for axial length? Non-contact biometry is most accurate way of measuring. We can either use your ILMaster 700 or Lenstar myopia, both of which we are having in our setup, and that will be because they are so accurate, they can pick out even very small differences in the axial length, and it gives an average of 5 readings, so it's going to be very accurate. And with the Lenstar myopia machine, these are the kind of graphs that we get. So there is software inside based upon already pre-filled data, which gives a approximate projection of what we could expect over the next 10 years. It is not 100% accurate, but it is very useful to explain to parents. When we show the graph, all of them start listening very intently, because it's quite scary to say like 0.5 at the age of 6, looking at -7 at the age of 16. So it really has an impact. And so treatment strategies already has been detailed. So behavior, see, the kind of classrooms that we had before in India was much suited for myopia control. Right now we are having rooms which are completely air conditioned, no window, nothing, and no sunlight. But in the Western and even in Singapore, now they are making classrooms with glass walls. so that the sunlight will come inside. And so we need to definitely communicate to the education authorities and the school that they should not cut all the recess periods and put them into class. The problem is, even if the parents understand, the school timings for most children is like 8 to 6. And with all the tuitions, there's absolutely no time to spend outdoor. That is the sad part. Glass and frames. Finally, it is very important to look at the glass and the frames, because if they are ill-fitting, then it is not going to help in myopia control at all. So this is the guideline that we are currently following, like less than 9 years, 0.5 per year diopter or 0.3 millimeter per year, and over 9 years, 0.3 diopter per year or actual length 0.15 millimeter per year. So this is how we are grading it right now. And this is the progression chart where our optometrist, she also fills in the previous actual length, the today's actual length, and we see the difference, and we calculate the progression rate per month, because all are not coming at regular intervals. So if we keep on seeing the number, we know the progression rate per month if we calculate whether it is normal or abnormal. And then if we add some intervention, like quite a few of our patients are on combined treatment, like low-dose atropine plus some other treatment. So then we know exactly where we have introduced atropine and how it is progressing. Peripheral hyperopia, if you are documenting peripheral hyperopia, relative hyperopia patients may respond well to the control glass designs, whereas if you have relative myopia, then low-dose atropine may be a option. That is why. And lag of memory, so you need to give a near. So these are the most important things that you need to understand when you are prescribing a control glass. So analyzing our results, we opened the myopia clinic in Arvind Hospital last June. Before that, as you can see, we had started dispensing some glasses, but we didn't get any entry on any patient data, nothing was coming. That's why we put the clinic. It's even though it is, you may have a physical clinic, or at least you can have an EMR, that there is something as myopia, so that all the patients go inside that. And that way you can get a like approximate number. Like last May, we 1,000 patients into myopia clinic in just 1 month. So that is the incidence that we are looking at right now. It is quite a significant percentage of our OPD. So what we saw is, even currently, more than like 65% of the patients are opting for the single vision glasses. Around 12% are going for myopia control glasses. I am not a taker for first line atropine because of compliance issue. Many patients stop in between, and then you don't understand whether it's a rebound or whether it is they are not responders, or compliance is a key challenge, especially because our OP is very busy. Even though we explain, they don't follow. And glass means anyway they are wearing it, so the compliance issue really comes down. And 18% didn't have a change of glasses. And when we did a study among the parents who are patients who are using single vision glasses, we saw that around 67% needed a change at 6 months. So, is single vision glasses good or bad? We generally we go on the affordability, but for very low myope, like 0.5 or 1 diopter myopia, not wearing glasses is better than wearing a single vision glasses, because the relative peripheral hyperopia is made worse by wearing a single vision glass, because the focus is going behind your retina. So the single vision glass may in fact contribute to progression of myopia in a patient who is having relative peripheral hyperopia. That is why there is so much of progression with single vision glasses. Though currently the control glasses are not affordable for a majority of population. So we need to talk to the stakeholders there and try to reduce the price, but the design of those glasses, they really bring down the percentage of progression, is what we have seen with our experience. Even low-dose atropine is a good option, provided you can ensure compliance. Once you start, minimum of 2 years the patient has to use it, minimum of 2 years. So on comparison between the DIMS and the Hall lenses, we had given around had around 80 patients of DIMS with 6 months, minimum of 6 months follow-up. Of that, you can see that the actual length progression per month, that comes to around 0.1 per year on an average with the DIMS, and glass has been replaced in 11 patients in 6 months. And that is the, compare the percentage with the single vision glasses. Single vision glasses is way more than this. And the Hall lenses seem to be doing even better, but the number is very less. It is not a comparable number. 30 patients with 6 months follow-up, you can see that two of them have replaced the glasses, and you can see the very good axial length stability there, like 0.002 per month. This is what we can measure with the non-contact biometry. So follow up, if there is troubleshooting, how do you need, once you prescribe DIMS or a Hall lens, you need to see within a week if there is adaptation issue. So earlier we were calling every patient, but now we tell them that if there are issues, they can come in, because otherwise it's difficult for them to take a leave for that. Else we see every 6 months. And if there is significant progression, in axial length we can pick up prior to seeing in a power progression. So if we find a significant progression, I add low-dose atropine as a second line. So once you add low-dose atropine along with the control glasses, the percentage, the control comes around 80%, whereas with the glasses it's around 60 to 70%. So you get additional control there, but you need to ensure compliance. Low-dose atropine, initially you see after 2 weeks to look for any possible side effects, and every 4 months thereafter. And when to stop is, see, you are looking at least a year of axial length stability, not power stability, axial length stability. So red light therapy is still very nascent stages, and the thing is, it is a laser. So we need to really be sure that we don't know about the long-term side effects of this therapy. There has not been enough studies on this, but there may be some, in couple of years it may be a good approach. So collaborative approach to myopia control is definitely essential. And the most important is not a buy and buy type of business model. We need to get the family on the same page, achieve patient compliance with whatever intervention that you are suggesting. Whatever intervention it is, environmental and behavior modifications are the most important. Without that, the entire treatment falls flat. Awareness creation and knowledge, like a lot of meetings we keep talking about myopia control right now. So I would say that this is the need of the hour for the future of our youngest patients. Thank you.
Thank you very much, madam, for the elaborative session. Purpose served. Thank you very much.